There are some clinical trials that are particularly attractive in my opinion. I'm very intrigued by all these frontline studies for Asciminib that are going on. We know that we do have good frontline therapy, but with the second generation TKIs, which is one of the best what we have now for frontline therapy, we get at most 50% of patients eligible for treatment discontinuation. Can Asciminib do better than that? Can we get to 70, 80% of patients eligible for treatment discontinuation? And if they discontinue therapy, is it the same, 50% relapse, or could it be that it's a better level of eligibility? So it's intriguing. Of course, depending on the data, we'll have to see how do we incorporate them in algorithms, thinking about cost and all the things. But first, we need to explore what it can do. There's also some of these trials with Asciminib looking and with ponatinib looking at second line after second generation TKI. We don't have good treatment for that. What we do is rotate other second generation TKIs, but that doesn't work very well. So we don't have a good standard for patients that have the second line need, but after a second generation TKI frontline. And then the third are different approaches is looking at in the treatment-free remission. How do we break that ceiling that we have where overall only about 25 to 30% of patients can successfully stop therapy? Is it by using Asciminib frontline? Is it by combining? Is it by adding something else that has nothing to do with the TKI? We need to understand that better, and there's several trials that are looking at different approaches there. So those are exciting, interesting. Hopefully they show some light on how we can improve on this.